Hello everyone. Today we'll discuss about thyroid storm. It's a new topic. It's a new topic from a new session, endocrine abnormalities from our channel. So without wasting much time, we'll go into the topic. So what is thyroid storm? It's a life-threatening. It's a life-threatening hypermetabolic state. In a patient who is hyperthyroid. Okay. So incidence is So incidence is very rare, but is associated. If it happens, it is associated with 20 to 30% of mortality. Okay. So what are the precipitating factors? It can be because of vigorous thyroid manipulation in a patient who is already hyperthyroid, or it can be because of palpation of thyroid gland, ingestion of thyroid hormones, mainly thyroid surgery. During thyroid surgery, it can happen in a patient who is already hyperthyroid, or during radioactive iodine therapy. Then iodinated contrast dies when we give, or when the patient is in a withdrawal of antithyroid drug therapy. Okay. And these are the thyroid related precipitating factors. So when we go to non-thyroid precipitating factors, it can be because of infections or CVA, cerebrovascular accidents, or it can be because of CHF, congestive cardiac failure, or MI, or any surgery itself is a stress to the body, so it can also precipitate a thyroid storm, or DKA, or any trauma. So coming to that is done with the precipitating, that is for the precipitating factors of thyroid storm. Now we'll come to clinical features of thyroid storm. Clinical features. So if the patient is taken, if a hyperthyroid patient who is having a multinodular goiter or any swollen gland taken for operation, and it can the clinical features can occur intraoperatively also, like malignant hyperthermia can be there. Hyperthermia. This malignant hyperthermia can be seen intraoperatively, or it can also be seen 6 to 24 hours postoperatively also. Other clinical features are like nausea, vomiting, diarrhea can be there, or the patient can have altered consciousness, coma, confusion, or seizures can also occur, and heart rate can be more than 140. It can be sinus tachycardia or any other arrhythmias also. It can be atrial fibrillation also. Fever, MI, cardiac failure, increase in CPK, or metabolic or respiratory acidosis can also be there. Metabolic respiratory acidosis. Okay, coming to investigations. Lab analysis usually not useful because it is an emergency and we can't rely on the lab investigation in that emergency. We have to act quickly, but we can still see leukocytosis, or hyperglycemia can be there, increased transaminases, or bilirubin. ECG, chest X-ray, everything can be done. So we can do all these ECG, X-ray, urine analysis, blood culture to identify the cause. Of the precipitation. So ECG can be done. It can show some arrhythmias. Okay. Then coming to the treatment part. So if we are getting some infection, we have to start antibiotics. Patient in congestive cardiac failure with atrial fibrillation with fast ventricular rate, go for digoxin. If the patient is having DKA, treat it. So coming to the non-specific treatment for a thyroid storm, we have to go for antithyroid drugs. They are initiated as first line therapy. Propylthiouracil, 1 gram loading dose, then 250 to 500 milligram 6th hourly perorally or via NGT. It adds within 1 hour. Or we can use methimazole also. Methimazole 40 milligram per hourly followed by 25 milligram 6th hourly per hourly. Then next therapy is iodine therapy. Iodine therapy, we have to give sodium iodide 1 gram IV 12th hourly, or potassium iodide 5 drops TID via NGT, or lugol-iodine 5 to 10 drops TID per orally or via NGT. So this should be given 1 hour after PTU, propylthiouracil. Okay, or we can also use hypenoic acid 1 gram IV 8th hourly for 24 hours. Lithium carbonate can also be used. It's found useful, milligram per hourly per day. Okay, then coming to next therapy is beta blocker therapy. Beta blockers. So we give IV propranolol 0.5 milligram per kg IV every 5 minutes till heart rate is below 90, then followed by 2 milligram IV 4th hourly. Okay, then IV esmolol can also be used. IV esmolol, it is 0.5 milligram per kg IV bolus, then 50 to 100 mics per kg per minute infusion. So we can also use combined alpha plus beta blockers or alpha 2 antagonist also. Then coming to steroids, hydrocot first choice 100 to 200 milligram 8th hourly. Dexamethasone is also found useful. Dexamethasone 2 milligram IV 6th hourly. Supportive therapy, coming to supportive therapy, oxygen. If the patient is not able to maintain his airway, or the patient is unconscious, patient is very irritated, he is not maintaining his airway, patient is having froth from the mouth, patient is throwing a seizure, okay, we have to immediately intubate the patient. So intubate the patient and put him on mechanical ventilator. So oxygen therapy, Pitfalls, again RT should be inserted to give many of our drugs. IV saline, glucose to correct electrolyte abnormalities and hypoglycemia if it is there. Inotropes, if the patient is not maintaining his BP, MAP is less than 65, go for inotropes. If CCF is there, go for diuretics. And we have to monitor the temperature. If the BP is less, or the BP is on the higher side, or the BP is fluctuating, and the BP cuff we are using, it is not giving reliable readings, go for invasive BP monitoring. And also a central line to guide the fluid therapy, or to give inotropes. If the patient is on high amount of inotropes, put a CVP. Yeah. Then surface cooling. Surface cooling is also an important step in thyroid storm. So we have to give cold lavage of body cavity. We can give ice packs, cooling blankets. Tepid sponging can be done. If the patient is having high temperature, we can go for drugs also. We can give PCM 650 mg or 1 gram. This is per hour. This is 1 gram IV 6th hourly. Yeah. So in refractory cases, we have to prolong the mechanical ventilation. We have to, if the patient is going into sepsis kind of stage with infections and having shock liver or acute kidney injury, not pouring urine output, we have to go for hemodialysis also. Hemodialysis and plasmapheresis also. Plasmapheresis in refractory cases. So that is all about thyroid storm. This is very brief description about thyroid storm. Hope you have got some idea about thyroid storm and its management, clinical features, precipitating factors, clinical features and management from this video. So next section we'll come up with a very new video. Thank you so much.